Again, thank you guys for the invitation. I will try to keep your blue seal as EHPBA president because I think you're doing a marvelous job, and I see a lot of people from around the world here, including Australia, as you mentioned, and the US. I changed my title slightly this time because I think the whole story needs to be minimally invasive, because then it will end with robot, but then you got the full story. I got two disclosures. One, basically I got some funding, our group got some funding from all the companies, so I guess that makes me a bit more neutral, and Dutch Cancer Society. But the second is this, and this is our experience, and I think this is important, because if someone tells you things are easy, etc., you need to think, does that person know what he's talking about? If you've done too much, maybe you also look different at that person. So that's why I'm just give you our experience. So at all the Whipples, I've been personally, and 90% of the distals I did personally, and I did all the laparoscopic livers, and now a colleague is doing the robotic liver. So we are doing since 2018. So we started like December 2017. We do every Monday a robot Whipple, and every Thursday we do 2 robot livers, non-stop. Even at the moment during the randomized trial. So that is important to take into account while hearing me speak. And basically, this is a story. This is a story of going from 0 to where we are now. It is not just a Dutch story. There are quite a few Dutch studies in it, but I tried to put all the trials and everything in it. So this is one wrap-up story. I'll try to do it in 20 minutes. All MIS pancreas surgery, the entire story. So why MIS pancreas? And what is it? Well, it is lab and robot, and I guess there will be other things to come. Why? That's the main impact. It's not to work with a cool robot. It is to minimize impact of surgery on our patients. In whom? Selected patients, and I don't have a lot of that in here, but clearly these patients are heavily selected. For the Whipples, about 1 in 3 on a robot, and for the distals, about 9 in 10. Basically, anyone with a smaller tumor and no vascular contact. And I want to speak about evidence, training, and volume with you guys. So first of all, I think most importantly, the current guideline, the Miami guideline, Horatio Esbin, you see here, who led the initiative with Herb Say, Mike Kendrick, and myself and Maura Boilal. There was a great job. You see all of us. You say some of those you see here are actually in this meeting. I see Jin Hay from Hopkins in the meeting. So systematic reviews, recommendations, excellent methodology, and what was great that we had an external validation done by a committee of open pancreatic surgeons. So that was very good. So they made sure that we were not being overly optimistic. So just one slide of the guideline advice. So it says that if you want to start doing minimally invasive pancreatic surgery, find a training program. And if you want to do minimally invasive Whipple, which no one says you should, there's no reason. So if you don't do minimally invasive Whipple, you can still be an excellent pancreatic center. No one says you should. But if you want to do it, make sure you're in a center that does at least 50 Whipples per year. Why? Because you need to do at least 20 MIS. And in order to find 20 for MIS, you need to have a volume of 50 in total. If you do less than 20 MIS Whipples, your mortality will be worse. So this is very important. And I know for 90% of the centers in Europe and 98% of the centers in the US, they don't reach 50 Whipples per year. So this is crucial. And then we advise the 2-surgeon approach, especially in the learning curve, but also during the procedure, because it's just a whole lot easier. So please put this app on your phone, tell all your residents to do so. Pancreas Guidelines app, it's for free, and it has this and several other guidelines. And then end of September, Moa Boilal, myself, and a large group of experts and PhD students are working on the Emips guidelines in Brescia. So look it up online. You're welcome to come. So now this next slide is going to be all the randomized trials. So all the randomized trials. So at the moment we have already 11, 6 of them published, 2 of them completed, not published yet, 2 of them ongoing, and 1 stopped. So first for distal, these 4 randomized trials, I'm going to briefly touch upon them later. The Leopard 1, so mostly lab, but also a bit robot, distal in the Netherlands, published, multi-center for the first one. Lapop trial from Sweden, BGS, the Diploma 1, completed, not published, and now in Heidelberg ongoing the DISPAC 2. On Whipple, we got 7. So I'll touch about the published ones. So the plot trial, First one from India, VGS, Padulab from Barcelona, Annals of Surgery, then the Dutch trial, Leper-2 in Lancet. 2 years later, also in Lancet, the big Chinese trial. And then the Europe trial, interesting, is the first trial with only robot, completed in Heidelberg. Data are not there yet. Jin Hay, who's in the meeting, did a trial in Hopkins, but had difficulty randomizing patients in the US because they just only want the robot. Maybe we can touch about that in the discussion. So that trial was stopped early. And at the moment, the Diploma 2 trial is ongoing in Europe, and we randomized, I guess, now the first 45 patients. So only a few of these, 5 of these, include robot, and only the Europe trial and the Hopkins trial include solely robot. So we are still far from reaching the final evidence on robot. Okay, so now I want to start with lab and robot distal, and then I'll do lab Whipple, and then I'll do robot. So let me start distal. So I want to tell you this story about how it came along in the Netherlands. So for laparoscopic distal pancreatectomy, we set out with retrospective studies, training, prospective studies, and a trial. So interestingly, in this period in the Netherlands, 2005-14, only 1 in 10 of the distals in the Netherlands was laparoscopic, only 1 in 10. And of those, more than 1 in 3 was converted. So clearly this tells you that we were not up to par yet. So we set up a training program with my friend Marc, and you see here some of the documentation from the training program. You see 4 different hospitals, and we trained all these surgeons. So the result was that there was a 7-fold increase in the use of MIS distal. In the first 130 patients, the conversion rate went down from 38% to 8%. And this includes the training patients. And the mortality in the first 130 was 0. So we're very happy with the result. We said immediately thereafter, and sorry if you heard this story, this part of the story before, but we did a randomized trial, Leopard trial, all the trials I'm going to show you, in the ones I was involved in, patients were blinded. You see here the giant dressing stays on for 5 days. We ask the patient day 1, 3, and 5, what do you think? Usually they don't have a clue. In the current trial, they all think they had robot actually. So this trial was published in Annals of Surgery, and you see here that primary endpoint was time to functional recovery, meaning you had to tick all these 5 boxes. And that was 2 days quicker for minimally invasive distal, which was about 95% was laparoscopic distal. But what we had not anticipated, that each of the components of time to functional recovery was also 1 to 3 days quicker with minimally invasive distal. So we're very happy with this result. Then Bergtorp Björnsson from Linköping did a single center trial, randomized 60 patients, lab versus open distal, basically the same outcome. So the only topic remaining is, I guess, one of the topics remaining is distal for cancer. So this is the Diploma 1 trial. Diploma 1 trial was finished over a year ago. You see the randomization because of COVID was slightly slower, but I think we did very well. So patients were randomized in 35 centers in 12 countries. So this was remarkable, and I can't give you the results now. This was excellent. Then what we're currently working on is Diploma 3. Diploma 2 you'll hear in the end with robot, but Diploma 3 is robot versus laparoscopic distal for all indications. So that was the story for distal. So basically pretty straightforward. If you know how to do it, if you know how to select, basically you can almost do all patients, laparoscopic distal or robotic. And the difference between lab and robot distal, we have to look at further trials. So now lab Whipple. Basically, I told you before, Palanivello from India and Yasi Poves, who sadly passed away from a brain tumor in Barcelona. So if you look at the conversion rates, you see that the India group was very experienced, 3% conversion, and you see the Spain group was less experienced, 23% conversion. But you see in the India trial, low mortality, complications, fistula, hospital stay 6 days shorter. So a positive trial for laparoscopic Whipple, not much differences, but that's basically what you probably expect. So hospital stay was shorter, and from the Barcelona trial, actually significantly less complications. Fistula rate not higher, and hospital stay also 3 days shorter. So these 2 monocenter trials, highly experienced, a little less experienced, positive for hospital stay. So we repeated the thing in the Netherlands that we did before. We did a training program. We did 114 laparoscopic Whipples in 4 centers, published them, which is rare because usually people do not publish their first cases, and you know why. During the training program, 19 lab Whipples were done per year in these 4 centers. Conversion rate was 10% and fistula was 35%. So clearly 35 is high, but obviously these patients are selected, and they're not selected for a wide duct, but they are selected because of easy tumors, and they have a higher leak rate. So 90-day mortality, 3.5%. We were pretty happy with that. And then we said, there was maybe a mistake. We can have a debate on that, but then we said immediately thereafter, do the randomized trial, basically copying what we did with the distance. So this is the Laproscopy trial. You may have heard about it, which was stopped early by the Data Safety Monitoring Board. They advised us to stop after 99 patients because the complication-related mortality was 10% with lab and 2% with open. So this difference could still be by incidence, but if you look at the primary endpoint, time to functional recovery, again, as in the other trials, we were not helping these patients. So they were not recovering fast. So we were not helping them. There was a safety concern. Conclusion very clear, stop the trial. Stop the trial, which is what we did. Interestingly, though, if you look at the leak rates, PJ leak rate and HJ leak rate, exactly the same. So the problem was not in the anastomosis. You can train that laparoscopically, 3D, pretty straightforward. Complications happen earlier during resections with bleeding, etc., and post-op bleedings. So then come this very high volume Chinese trial. I think it were 6 centers. Each of the surgeons had done more than 100 laparoscopic Whipples. And you see that here, again, if you look at the conversion rate, that tells you pretty good how advanced someone is. 4% is low, mortality the same, complications the same, fistula the same, low fistula rate, but the same. And then off-bed activity, first oral food, hospital stay significantly shorter for lab, but the differences is not so big. And you can tell that this is an Asian study because in Asia, in China, you get discharged once you have no more symptoms of surgery altogether, 0 symptoms of surgery. So in the US, you get discharged when you eat. In Europe, you can discharge when we can give you some tube feeding or whatever sips at home. But in Asia, you can only go home if you have no more signs of surgery at all. So that's why these hospital stays are always longer and, well, 1 day faster in this trial, which is a positive trial and published in Lancet Gastroenterology, which I just found out as of today as an impact factor of 75, for those of you interested. Yes. So if you put that all in one table, orange is sort of similar, green is positive, and red is potentially worse. You see that the benefit is hospital stay. And here the Dutch trial, which was very early on in the learning curve, concern. Okay, so this led us to a meeting in the Netherlands with all the lab Whipple surgeons in one room, closed the door, turned off our phones, no Twitter, and we looked at the videos of the patients who died, and we had a good discussion. And we concluded that part of the problems with lab Whipple were because of randomization. We randomized 1-to-1, so the volume went down 50%. So some centers were doing only like 8 or 10 lab Whipples per year, which is clearly not good. But there were also some intraoperative issues, and we said, okay, let's make a decision, and we reached consensus that we would stop doing lab Whipple. We would move to robot Whipple, but only in the centers that do at least 50 Whipples in total. So some smaller centers stopped, and they joined forces with the larger center. So which is what we did in the Netherlands. So robot Whipple, third part of the story. So looking at Pittsburgh, which in the Western world is clearly the leading center. You may know this publication, 2019. They do 50 robotic Whipples per year. It takes them now median 6.5 hours. So please remember this figure because I'm going to show you the Dutch data. So 390 minutes, okay? And they reached the plateau after 240 cases. So remember this. Complication rate, 24%. Fistula rate, very low, 8%. Mortality, 1.4%. And then the American hospital stay, very short, 8 days, median. But when you look at the US altogether, this is 2021 data, again from Ahmad's Suraigat's group. You see that there is an increase. They are doing 225 robot Whipples per year in the US, but of those doing it, only 121 do less than 1 per year. Less than 1 per year, which is insane. And only 5 centers at the time were doing more than 3 per year. Now, these data have changed. Volumes are higher now. Jim can maybe tell us about it in the end, but you need to realize this. that when you look at nationwide data, you need to realize what is the nationwide volume. Conversion rate is also high, 15%. So again, we did a training program in the Netherlands, working with the great team from Pittsburgh, and Melissa Hawk had designed this training program. Here you see Melissa with us in Jawad. This is our lead scrub nurse, Shirley. Maurice Swart was also in the meeting, our PhD student, Oliver Bus and myself, and here you see Ahmad and Herb. So they came to the Netherlands for full weeks. And in these full weeks, Maurice drove them to several hospitals, and they were doing 3 to 4 to 5 robotic Whipples in 1 week in several hospitals in the Netherlands. So before they came, people read the very detailed technique description, they did video training, they did the Da Vinci simulator, and they did biotissue training, and they need to reach excellent scores. Only then we went to see a robot Whipple, and then they got a visit from the proctors. So at the moment, we've trained 8 centers. I've got an update on this number in the next slide. Also an update on this, and you see Maurice and Besselink, who come from Rotterdam, and Quintus Mona from Utrecht, with whom I coordinate this effort. So this is the most recent data. 635 robotic Whipples now performed in the Netherlands in 7 centers by 17 trained surgeons. The feasibility, proficiency, and mastery learning curves were reached a lot earlier than in the sort of pioneering centers. So 15 for feasibility, 62 for proficiency, and 94 for mastery. So your best, a lot earlier, a lot shorter cutoffs than earlier. Median center volume is now 22, and the national use of robot Whipple is 30%. I think 30% is the highest in any country in the world. If anyone knows of a higher country, please let me know. And you see how that went. We did lap Whipple first, and it stopped, and now we do only robotic Whipple in the Netherlands. So this is the outcome of the first patients: morbidity, surgical side infection, conversion rate 6.6%, fistula rate 27%, and 30-day in hospital mortality 3.5%. And basically, if you match this to open cases from the same fistula risk score, etc., it looks highly, highly similar. This is all these hospitals, A to G. Each color is one hospital, and this is the operating time. And do you remember the 390 minutes I told you from Pittsburgh, which they reached after 240 cases? So look at this. From the beginning, basically stable. And this is definitely not because we are better surgeons than Pittsburgh, definitely not, but because we did a training program with them, copy in great, great, great detail every single step of their procedure. And to me, this is the proof that we should do this from now on in all new procedures. It doesn't make sense to watch a YouTube video and start doing this at home. Finally, we copied this now to Europe. It's called the LearnWhat program. It's still open for those of you interested. You need to work in a center, though, that does 15 Whipples per year. It's endorsed by EHPBA. Again, exactly the Pittsburgh training program. It's free of cost. Everything is taken care of, also your travel. The only thing we ask in return is that you put your data in the European registry, the Emips Registry. So look at emips.com or contact your intuitive rep or myself if you're interested. So here you see the biotissue material. We first used it from Canada, lifelike biotissue, but this stuff comes from Felix Nichols' group in Heidelberg. It's beautiful biotissue. Is excellent to work with. So when you do your first Whipple, every stitch, you know exactly what to do, and you don't even have to think during your first procedure during these anastomosis. So it's very, very good. I made this slide just yesterday for you. Here at the right bottom is the group from Montpellier that visited me last Monday, and the Monday before was your friends from Newcastle. You may recognize some of them here. So these were all the visits we had in the last year or so. So I think this is excellent. And here are some of the centers that so far we have trained in Geneva, Lund, Copenhagen, Münster, and we did 4 more. So at the moment, 12 of the 20 centers have been trained in these places. But I mean, there are some slots open, so if you're interested, let me know. Especially, we would like to have a few more UK sites actually. And then we did courses. So this was the course we did in April. In the Netherlands. And finally, this is the Emips Registry. So you've seen it before, I think. We asked first to surgeons in Europe, well, would you like to join? And those who responded to the survey, they did a median of 45 Whipples per year. And of course, those who replied were all interested. And they said, well, okay, but it can't be more than 10 to 15 minutes per patient for data entry, which is what we did. So we made an online system using Castor. It's free. You can access your own data at any time. Clearly, we're going to do studies with this. And 2 centers per year get an audit. So we just had the first audit in Turkey, in Koç, very recently. And you see, as of now, we included more than 3,000 patients. Just in the few beginning years, we already included 3,000 minimally invasive pancreatic resections from 72 centers in 21 countries. So if you're interested, please join us. Even if you're only doing a minimally invasive distal, doesn't matter. So just one slide from the registry, and then I'll show you a little bit about Diploma 2, and then we'll close. So in the registry, in the first 2 years, minimally invasive Whipple was being done in 75% of the centers joining. Okay, of those doing minimally invasive Whipple, almost 60% was being done by the robot, and the figure is increasing. But only 1 in 4 of the centers meet the Miami Guideline Advice. And finally, in those centers doing minimally invasive Whipple, about 1 in 3 is being done minimally invasively. So that's interesting. So now we're running the Diploma 2 trial, as I mentioned. So it's a combined superiority and non-inferiority trial. Our main goal is just to show it's safe for complications. So the main aim is to show non-inferiority for MIS, but the most relevant secondary endpoint with the sample size calculation is you want to show it's superior for time to functional recovery. And to keep the experience high, we randomize 2 to 1. So we do twice more MIS than we do open. And most centers do robot. We have 2 or 3 who do lab. So you need to do at least 30 MIS Whipple per year prior to the trial, so you can reach the 20 even within the trial. And the most centers now offer robotic Whipple if they join only in the trial and not outside the trial, because otherwise I think you have difficulty randomizing patients. And you need to have done at least 60 MIS Whipples. So I'll skip this in sake of time. Patients are blinded again. Oh, one back. So these are the centers. We're looking forward to Heidelberg starting with the trial. Actually, they haven't not, but they're working on the ethics. The Netherlands 4 sites have started, and Italy has started. So these are all those joining. And then finally, we also initiated the Emips consortium, wherein the American Emips, the Asian Pacific Emips, and the European Emips, they join forces. I think this is wonderful. So take-home messages for you. 1, it is very well possible to do MIS training programs. We showed it for the LabS 1, which was followed by the Leopard 1 and Diploma 1 trial. We showed it for Lab Whipple, which was followed by basically the negative Leopard 2 trial. But that had a positive consequence that we started robot, LabS true, and now for you guys, if you're interested, learn what is available for robotic Whipple. And that has led to the Diploma 2 trial. So trials are becoming rapidly available. A few new trials with the results coming up. Laparoscopic distal, I think, is now the standard approach. For cancer, we'll tell you the diploma results at the end of the year. For laparoscopic Whipple, you clearly can do it very well if you're highly experienced. Robotic Whipple, I love this procedure. I think it's excellent. It's much easier than doing my laparoscopic Whipples, which last until 6, 7 in the evening. And our robotic Whipple, you finish at 2 and 3, and you feel like, let's do another one. But it is clearly complex surgery. We need more evidence, Diploma 2 trial, Europe trial, etc. And for the robotic distals compared to lab distal, we'll see a Diploma trial, Diploma 3 and other trials will follow. And then finally, but I guess by now you got that point, is that our advice is for MIS Whipple, fine, if you want to do it. No one says you should, but if you want to do it, make sure you only do it in a high volume center. So I want to especially thank all these PhD students who did 99% of the work. I want to thank my good friend Marc, and I hope I see you all live at ESPBA Lyon in June 6 to 9 next year. So thank you very much for your attention.
Thanks, Marc. It was a really great presentation, as always, really compelling data. And I think, well, all the things you're saying about training and minimal numbers of Whipples can't be more true. We'll reserve all the other questions for the end, and we'll give the panel a chance at the end as well to discuss with you. And I will give Tamara the chance to give her presentation first, and then we'll.
Thanks. Everyone can see that?
Yep.
As Adam said, oh, why is it moving on already? I'm currently doing a fellowship in Australia but I've had quite a lot of robotic experience as to why they've kindly asked me to present to you guys with such esteemed colleagues. So I first did robotic surgery first assisted in robotics in 2017, fell in love with surgery again. I think it's a fantastic platform and very exciting for the future. So I went on to do a robotic HPB fellowship with Professor Long Zhao at the Royal Marsden and Imperial College. I've visited Amir Zurakat, who you've heard about in Pittsburgh at UPMC, who really pioneered robotic surgery with Herbert Zay and later Melissa Hogue in the States, and they do 3 robotic Whipples a year. And I spent time with Yuman Fong, who needs no introduction, but is just a very innovative and exciting person in the States, really keen on robotics and digital technology and encouraging that. I last year was the RU Group representative for robotics and a member of the Royal College of Surgeons Radar Robotic and Digital Technology Committee. Before coming to Australia, I did a locum consultant job at the Mater Hospital in Dublin with John Keneally, who is an expert robotic liver surgeon, and we did the first synchronous robotic and colonic robotic resection in Ireland. So I'm going to talk to you a little bit about why we should develop robotic training. You've heard a little bit already from Marc about that, and how we should train, and whether training works or not, some essential requirements at the end. So I think robotics is the next generation of surgery. Even though I think it was 20 years ago that Pierre Giulianotti first did robotic Whipples, but still only about 10% of HPB surgery is performed with minimally invasive techniques worldwide. And a lot of that is because, as we know, these are very complex procedures to do laparoscopically. The resection's difficult, the vascular resections, and then the anastomoses are very complex. So that's put off a lot of people from doing laparoscopic surgery. But with robotics, that was going to increase. That's going to, it becomes easier, especially with training. Robotic surgery is widely available now. Most hospitals are gaining robots for mostly urology, but now colorectal and gynecology. And there's a lot more availability for, as HPB surgeons, for us to try to use the robot for basic procedures as well as more complex. And we know that it's comparable technique to open and perhaps laparoscopic, and it has some benefits. We published this of our first cases of robotic surgery, a single surgeon, Professor Zhao, compared to our open and laparoscopic techniques. And for robotic and laparoscopic, we had shorter length of stay by 2 days, as we've heard already from some of the other trials, reduced blood loss, less conversion rate of 24% in laparoscopic and 0% in our robotic cases of the first 30. And when we look at our first 65 cases, for the we saw a learning curve in terms of operative time after 20 cases. Now, this is probably better than some others because of the extensive laparoscopic experience we had before, about 100 laparoscopic Whipples before starting the robotic program. But we did not see the same learning curve for any of the post-operative outcomes. So really the learning curve whilst you're going is for operative time. I think younger surgeons now have a lot of enthusiasm for minimally invasive surgery. They've had advanced skills from doing other specialties, colorectal, upper GI, bariatrics, etc. And they come to HPB having very advanced skills and wanting to do more minimally invasive surgery. And I think this is the most important point, that is where we're going to be taken with robotic surgery in the future, especially with machine learning and artificial intelligence in terms of training, and also for the technology that will develop. I think with robotics, we're probably only at the 80s mobile phone at the moment, and the next 20 years is going to be very exciting, and it is going to improve patient safety, especially with artificial intelligence showing automated anatomy in real time, as we've started to see with lap choles. And in fact, Intuitive this year have invested $700 million into research. So it's not going away. And whether you like robotic surgery or not, or you think it's helpful for HPB surgery or not, I think we're on a trajectory that it is going to increase. But you need to train surgeons, because patient safety with any new technique is paramount, and it is different to an open and laparoscopic technique. It's a different platform, and you need to learn how to do it. This is a Michigan data of 170,000 cases and in the States. And I think this, we're seeing this trend in the States, and it's going to come over to Europe, that there is an increase in robotic surgery for all general surgical operations over the last few years. And in England, it's increased by 410%. Intuitive states an 18% annual increase in their robotic procedures globally. And these are now in England, the centers that have a robot. And this was from 2019, this data. So it doesn't even include the last 2 years where CMR Surgical and the Versius has had a big push and been put into many, many centers. You may remember these articles from a few years ago of a cardiothoracic patient that died from robotic surgery, and the coroner actually said that it was because robotic surgery was used. However, the surgeon had not been trained at all with robotics before doing the case. So we really need to avoid these cases in the future. You want to reduce the learning curve and improve patient outcomes, and only training can do that. So how should we train? We've already heard about the Miami guidelines. And in terms of training, they have stated quite clearly, although there is a limited evidence, as we know with robotics and HPB, that participation in a structured program is strongly recommended using virtual reality simulators, biotissue models, video review, proctoring, and remote telemonitoring. That a steep increase in the use of robotics is seen after training, or in use of minimally invasive, reduces blood loss and conversion rate after training, but you should be doing an annual volume of 20 per year per center. So I think you can divide training in robotics into 2 phases. One is basic training, robotic assisting, simulation, and dry and wet lab training. And the other is procedure specific training. And we'll look at some of the data for Whipples in particular, looking at watching videos, biotissue training, and proctored cases. So firstly, with basic training, you have to have assisted in robotic surgery, I think, before starting. It's really important to know the basics of the machine. I think only by assisting you learn the trajectories of the arm, how to use the instruments, which ones use, how it takes time to change the instruments, and you should try and reduce that. The restrictions of the arms, they're quite inflexible compared to laparoscopic surgery, and their troubleshooting. The simulation, the Da Vinci model has very good simulation. Models. There are about 40 on the system, looking at different types of endo-wrist manipulations, using the camera, using the 3rd and 4th arm, and energy and dissection, learning how the machine works. And any hospital that you work in that has a Da Vinci robot, you can go and ask the intuitive rep and start to do your simulator training. And I think you can do this at any stage really of your career. Then moving on to dry wet lab training is of a great advantage. We know, with laparoscopic, all now surgical courses will start with box training in laparoscopy. It's difficult. You've got to start early. And it's the same with robotics. It's a new technique. You should start to do the simulator, learn how to do dry training, and if you're lucky enough, on cadaverics and biotissue. We did a survey last year of all residents, registrars, and fellows were invited in the US, Ireland, and the UK. And I think this is really interesting, but I'm sure that in Europe, we are going to be following what is happening in the US already. So you can see here in the UK, over 60% of trainees have never been on the robotic simulator before, compared to in the US, every single trainee that we surveyed has spent time on the simulator, and almost 30% have spent more than 10 hours on the simulator. And in terms of then performing procedures as the console surgeon, 90% of trainees in the UK have never performed an operation on the console, which I would anecdotally say is very true. Most people have never been on the console. Whereas in the US, no one had done no operations, and 70%, over 70% have performed at least 15 operations on the robotic console. Now, mainly what they're doing in their residence training is hernias and gallbladders, which in the UK, I think we aren't really using the robot, and that we don't have the theatre availability. But I think this is the way we're going over the next decade. So you can start basic training early. These are 2 papers from Melissa Hogue. The first one, they trained 41 postgraduate years 2 to 4 with virtual reality tasks. And after 7 hours of training, 83% achieved mastery on the simulation tasks. So you can learn how to use the console. And they now have incorporated a 2-week dedicated training for all their residents in Chicago, at the University of Chicago. They have no other clinical commitments. They spend 2 weeks of their resident program in just doing robotics in theatre and on simulation. And they've tried to standardize training this way. And I think this is fantastic, and what most of the trainees in the UK would really like. So next, procedure-specific training. I'm going to look here more at training to do robotic Whipples in particular. This is from a paper in 2017 from the Pittsburgh group. And following virtual reality training, they did a biotissue curriculum, doing suturing drills. And as we've already seen, performing gastrojejunectomy, hepatocojejunectomy, and pancreaticojejunectomies on biotissue. So the first picture is from the Japan group who've taken the Pittsburgh approach, practicing their PJs. And this is me in Pittsburgh doing the hepatocojejunectomy on the excellent biotissue that they have. All of their videos for when you train are then sent off to be recorded with OSAT scores. And once you have a certain score, you can then move on to the next stage in trying to perform parts of procedures. So they then think that the next step of training should be moving on to a video library, watching procedures in their raw form. And I don't think you can ever watch too many. And I think this is one of the advantages of minimally invasive surgery, that a big part of your training is just watching videos, and you don't actually have to be doing them to take in quite a lot of information subconsciously of what instruments are being used, positioning, retraction, etc. And then moving on to the surgical curriculum, where you start with the easiest operative step. It's difficult probably, especially when you're first learning robotics, to go straight ahead and do Whipples. I think you need to start at basic procedures. And if you're doing Whipples, then starting with someone else who's trained in minimally invasive surgery, starting with the easiest steps, the choles, the anastomoses, which you've been able to practice in the lab. This is from the Netherlands group, the Dutch pancreatic cancer group, and Marc Besselink, who's already shown you their data from training the Pittsburgh technique, and similar things. So you start with training, doing the simulation exercises, and you need to get a 90% score on 26 of the exercises. Following on from that, you do the biotissue drills with hepatocojejunectomies and pancreaticojejunectomies. And at the same time, you're watching videos and you're looking at case observations and perhaps doing other procedures. You then redo the simulator exercises. At this point, you need to get a 95% score, and then you start to be proctored on site and further teleproctoring after that. We've already heard of the Pittsburgh technique has now been taken to Europe, and for the LearnBot program, you have to be a high volume tertiary HPB center to join with one surgeon who's through the learning curve, and you have to have access to robotic theatre 1 to 2 days a week. And I think this is important, and a restriction for us in the UK currently is that once you've trained, you need to practice, and we know that. And you know, trying to have dedicated robotic theatre time is very important to keep your learning curve going. So does training work? We did this trial a couple of years ago in Newcastle. We had 20 surgical trainees and 20 medical students that were randomized to either laparoscopic or robotic training. And they all had 6 hours simulated training on one day, and the following day did cadaveric operating. And they had 3 tasks: cholecystectomy, suture closure of a gastrostomy, continuous suture closure, and interrupted suture closure of a small bowel anastomosis. And then the videos were analysed and scored. So we found here the robotic group in orange and the laparoscopic group in blue, that of the first graph, this is the global rating score with maximum score of 30 points. And for each group and for each task, the robotic group outperformed the laparoscopic groups in terms of global rating score. And in the second graph, this is the number of suture errors. And you can see that the laparoscopic groups had a much higher number of suture errors than the robotic group. So we know that if you go on the console, you do simulation work and box training, then it's much quicker to learn and be good at robotic surgery than laparoscopic. The skills are easier to learn. This is the Dutch group. Again, you've already heard about this trial, but following their first cases after learning the Pittsburgh technique, they had fairly good outcomes. And the Pittsburgh trial has also now been taken to Japan, again, who've published on implementing this program and doing robotic Whipples safely following the training program. I think this is a really interesting paper that again came from the Pittsburgh group. And they looked at their three generations of robotic surgeons. Their first generation surgeons, Herbert Zay, Mir Zurikat, and so on, who were doing robotic Whipples with no training curriculum and no mentorship. Their second generation, who had mentorship from the first generation, but no training curriculum. And the third generation, who went through the training program and had their mentorship. And they had the third generation at each point had lower operative time, estimated blood loss, transfusion rate, and complication rate. So you can see that by going through specific training programs and by being mentored by people already through the learning curve, your learning curve is reduced. Low length of stay as well. So finally, what are the essential requirements? I think the most important thing is to standardize robotic training nationally and internationally, and to standardize procedures. Because everyone says that you can't standardize a Whipples, and I beg to differ. I think you can. There are certain steps that you can go through, whichever order you go in, as long as you try and do the same way each time, using the same instruments, watching the videos. You may need to change it a little bit, but that's part of the standardized technique, isn't it? If you can't do it this way, try this first, or this, or if you, and just knowing what instruments you want to use and exactly what step you're going to do next. I think basic training in robotics should start for trainees in the UK as soon as possible. We should be introducing this at an early stage, like laparoscopic now is done. Standardized procedural specific training and techniques. There should be more than one surgeon at each institution performing minimally invasive surgery, which is one of the Miami guidelines. More than 20 should be done per year. And you need to audit your outcomes and participate in prospective registries. And I think this is an interesting point, is that we don't know yet. Do you need to have open Whipples experience before doing robotic training? Should you have laparoscopic experience before doing it, so that you know positioning and to seeing on the screen what you should be looking at before doing robotic training? Is this necessary? And if we're going down the route where perhaps trainees are going to see more minimally invasive than open procedures, like we've seen in other, simple operations, cholecystectomies and appendixes and so on, does that mean that trainees aren't going to be able to do open anymore? And they're seeing that in urology with prostatectomies, that now robotic is the gold standard. And in some places, if you can't do it robotically, then they don't open and they don't operate. And the patient goes to have oncological management. And I think this is something that we need to think about in the future of where we want to be going with HPB surgery. Although on the other hand, there's always going to be open surgery in HPB. I think it's complex. There's going to be a conversion rate. And with the bigger tumors and vascular invasion, I think we'll still be doing a lot of open surgery as well. But some final thoughts. And all of this is because we need to reduce the learning curve and improve patient outcomes if we want to start doing robotic surgery. So thank you. And this is just a plug for Royal North Shore Hospital in Sydney, which is a very, very high volume pancreatic surgical group. And they're always looking for international fellows each year. Thank you.
Thanks, Tamara. There's a great overview on training for robotic surgery. I think I could start with a question. You already we discussed about whether trainees or maybe young consultants need to do open or lap pancreatic duodenectomy before going on to robot. So I think that for the complexity of pancreatic surgery, I think you have to do some open procedures before going into robot. It would be ridiculous just to go straight from watching videos to enter a robot Whipple. But how many open procedures do you think you need to have done? So, for example, you've come to the end of your training. How many do you think in your last 3 years of HPB training should, not yours, but any surgical training, how many open Whipples do you think someone should have done before going into a robot training? I don't know if Marc or any of the others have a comment on that.
I think I don't think there's any data out there to say how many you need to have completed your learning curve. All the papers that have been written, people have already done a lot, and learning curves vary significantly. I think doing minimally invasive surgery reduces your learning curve with open as well, because the views you get and the planes that you see and the anatomy that you see, in my opinion, is much better. And everyone has a different amount. I think you have to be competent to do each stage of the procedure. And as a trainee, it's difficult, isn't it, to just do that it completely independently, each part, the whole Whipples. But a lot of people will say 20 is a number that keeps coming out that you need to have seen and done before doing it. But you can never do too many. And I don't know whether you need to do open in 20 years' time. Do you still think that doing open over robotics is going to be really, really important? People were saying the same with cholecystectomies and appendixes. Appendixes even 10 years ago, I remember people saying, oh, how is anyone going to do open? And now there's not really a need to, unless you have to convert to lower midline and do a right hemicolectomy or something. So I think that's definitely still up for debate. And we may see in the future that if you're only doing minimally invasive pancreatic resections and just doing open for very, very complex, or if you need to convert.
Oh, fair enough. Yeah. Christian, you've got your hand up. Do you want to have a comment on that?
You're muted,
Christian, you're muted. Yeah.
Can you hear me now?
Yeah,
for sure.
Thank you very much for these nice talks, both of you. You gave a great overview about the robotics and how it's evaluating, or the evolution, how it's going. My question is always, if they're coming new techniques, new gadgets, everybody wants to jump on. And how is this regulated somehow? Who gets access to the robotic? Very concrete, for example, maybe for Professor Besselink in your center, who can start with robot? Is it the first year resident telling you he's interested in robotic surgery? Let him do. Do you classify those residents who can do the robot, or Is there no resident doing the robot? And how about the olders who are already 20 years experience, who have a lot of open or surgical experience, and they also want to join the robot? I see the biggest problem I see or I experience is always the access to these tools, right? Everybody wants to use it, everybody wants to learn. And how do you?
Okay, so we set up a system. It's called the Amsterdam 1, 2, 3 classification. Anyone in the hospital wants to spend time on our 3 Da Vinci's has to go through a committee. Guess who chairs that committee? But nevertheless, so every procedure is ranked as 1, 2, 3. 3 meaning everybody consensus there's no benefit of robot. So appendix, cholecystectomy, right? So you won't get time. 2, debatable, more evidence needed. You may bring in a program, and 1 potential benefit you can go. We said as a hospital, we only want procedures on a robot that you do basically every week. So we only want high volume programs. So we do robot Whipple once a week, robot liver twice a week, robot kidney 3 times a week. What else we got? Robot kidney donation twice a week. So we only do stuff on the robot high volume. If so now the colorectal team wants to start, they have to present A, to this committee, a plan with training, etc., and show their volume. And B, they need to get to the finance department to get the money within the hospital. And then we see if there is a space. And clearly we already need the 4th robot. For the residence part, every new resident who's senior, who spent time with HPB, we ask them to get their driving license with Intuitive. And for instance, for HPB, we do the gallbladder at the very end of the Whipple resection phase, and they then go sit in the console and do the gallbladder. So we
during the procedure.
Sorry?
So you share during the procedure, you change, or they?
Absolutely. We also do during the Whipple, we also change. So one surgeon does the resection phase. So it takes from about say 8:45 to 11:45. It lasts 10-15 minutes. The resident does the cholecystectomy. Then we take a 15-minute break, and then the surgeon swap, and the other surgeon goes sit behind the console to do the anastomosis, and the other one goes on handing the sutures. So everyone we do with 2, because if you don't do with 2, the one guy who's always at the bedside feels inferior, and he will stop helping you. So, and if we train within LearnBot, we say you need to take 2 in the beginning, 3 in the end, maximum. And the worst thing that you can happen is 2 young guys who basically know how to do it, and then there's a senior professor who just wants to jump in for 15 minutes. This is lethal. This should not happen. So you need fixed guys in the department doing robotic Whipples, and not everybody, because results will really get a lot worse. And I realize this is difficult in some scenarios, for instance in the UK, where a patient gets referred to a certain surgeon. But I think for outcome, this is really crucial. It doesn't take much for outcome with robot Whipple to be worse than open. So you need to be super standardized, very high volume, few surgeons. This is absolutely critical.
And how about this? Sorry, go ahead.
No, does that mean, can you envision a situation where this is not the case anymore, so that robotic surgery becomes so commonplace that it's just another way of doing it?
Yeah, could I don't know what's in the future. I mean, like I think Tamara put it beautifully. I mean, if you now start driving, you start learning driving a car.
Yeah.
We don't teach you first how to ride a horse. You go immediately in the car. If we learn someone doing a lap chole, we don't teach him anymore to do an open chole. There needs to be someone in the department who you can call in case of a conversion, clearly. But so I have no idea where the future will be. But we have done what is it now, almost 190, 200 MIS Whipples, and I've been there for every single one. And I still really worry if we go split into 2 teams. So it is challenging, but clearly the day will come that it will become more commonplace. Yeah, but you must remember that the benefit for the patient is small. So the smaller the HPB operation, the bigger the benefit for MIS. You see for laparoscopic hemihepatectomy in the Orange 2+ trials, only 1 day. Laparoscopic Whipple is 1 or 2 days. So the benefit is not so big. So if your volume is a bit less, don't worry, just do open Whipples. It's not a big problem. I mean, you're not harming the patient. Be careful.
You know, you've shown a lot of evidence about how training and implementing these programs, you can get better outcomes with, like you said, length of stay, blood loss, etc., etc. What about for pancreatic duct laminar carcinoma? What about the lymph node harvest, the resection margin, the overall survival? Do you have any data about that? Can you comment?
Yeah, so 2 days ago, Marc and Carl, the PhD student, showed us the Diploma 1 trial results. I can't share them now with you, but I wouldn't be too concerned about that if I were you, for the distance. And for the Whipples, that will be Diploma 4. So robot versus open Whipple for only PDAC. We will have to show, but these patients are selected. So for all the studies, the criteria have been BMI below 35, no chronic pancreatitis or recurrent acute pancreatitis, and CT scan maximum 28 days old, not any sign or any concern of vascular involvement. So these are super selected patients. And in these patients, I'd be highly surprised if there's you can see it so nicely, you're under the SMA, just a beautiful image. I'd be highly surprised if it's worse.
So no neoadjuvants either, obviously. Then these are
also
all...
yeah, sure. No, neoadjuvant doesn't matter because neoadjuvant improves outcome of pancreatic surgery. So if you do neoadjuvant chemoradiotherapy, you basically have no more grade C fistula. We showed that in the pre-OPEC randomized trial. So we do include neoadjuvant patients, but they only the ones who were primary resectable. So not the ones who had vascular contact prior to chemo, but if you had a primary resectable tumor and in a randomized trial you get chemo. So just today we did a patient in the Diploma trial, was randomized to open, who had neoadjuvant in the trial for resectable. But that's no problem.
Okay, so nothing that would need a vein resection at this stage.
Exactly, yeah. You can do it. We've got, for instance, people in the Netherlands, so for instance, in Rotterdam, who do that quite regularly. But I mean, we have 1 robot day a week, and we need to do 3 Whipples per week. So we need to 3 or 4, so we need to select.
Okay, it makes sense. We have a hand up, Naeem Ahmed. Do you want to ask a question?
Yeah, his question is in the chat as well. I'm not sure if that's the same question, but he wants to know how to access the Amsterdam or Pittsburgh videos. I think.
I think you have to be part of the course currently.
Yeah. What you can do in the chat, you can send a message to a guy there. Maurice, are you still there? Maurice Swart. He's also got his own YouTube video with a lot of this YouTube channel with a lot of videos on it. Otherwise, you just email me. But indeed, the full Pittsburgh video link we only give if you join the program. Yeah. But there's a lot of videos available.
There are a few other questions in the chat actually.
Yeah,
Tamara from Rich Lang. Do you think that these training models are currently realistic for the UK general surgical training program as it stands? I ask this because we're at a stage when consultants are training on the job, and the training program now has a focus on emergency general surgery in the UK. How can trainees fit all this into their training program? Do you agree to implement this? We're going to prioritize this, and trainee associations should help drive the change.
Yeah, thanks, Rich. I saw that. I was trying to reply, but I couldn't do 2 things at once. I don't think it takes a lot to do the initial robotic training. So you saw with the Melissa Hogue with her trainees now that they only need 7 hours simulation training to get mastery in just using the console. And now the simulation modules are so good on the intuitive system, and they're going to get better. So they've already got hysterectomy and prostatectomy models that take you through labeled operations on the simulator, but they're pretty realistic and telling you what instruments to use and what vessels to cut and dissect and so on. And hopefully that will increase with the number of operations that you can do. So there's so much you can do on the simulator before going to the patient. And I think that's the advantage of robotic surgery actually for trainees, is that you can do a lot without having to get that operative time that's so difficult to do more and more for specific procedures. So 2 things. Firstly, anyone who's interested, I think, can go in their evenings and weekends when the robot's not being used and ask your rep to set you up on the simulator. But secondly, doing a 2-day, 3-day course just of simulation is not difficult. And if you incorporate it into the basic surgical skills training or something, I know robots are expensive and funding is the main issue at the moment, but I think that's what will happen in the next few years, that getting happy with the console and the simulator is something that's very easy to introduce into programs. Now, then going actually to operate on patients is more difficult. But that will increase as the numbers increase. At the moment, yes, people aren't through their learning curve, and there's not many places doing it, and it's very small numbers. But I think with initial simulation, there's so much you can do before actually operating on a patient, and that's very easy to incorporate into training programs.
Felix.
Yes, Marc and Tamara, thanks for your excellent presentations. You were both talking about learning curves a lot, and this is certainly one of the most interesting topics at the moment. However, what we always try is to take the learning curves out of the trials, especially the randomized trials. Do you think we are looking at it the wrong way maybe, and we should do a randomized trial focusing on learning curves, for example, to compare the learning curve from 0 for laparoscopic versus robotic distal pancreatectomy, or even open versus robotic pancreatic duodenectomy for surgeons who have not done these procedures before?
Tamara, you want to start?
Sorry, yeah. The point, sorry, can you ask that again?
No, I'll answer first, and then you can do after me. So this is what we did in Leopard 2. We did a randomized trial, basically by intention during the learning curve. But these surgeons that just did the Leopard 1 trial, the same surgeons, they just did a training program with good results. So we were immediately, so say after the first, so say they were just past the safety learning curve. And you know what happened? And I got hammered badly in the US, badly, because they were accusing me of killing the technique. And actually a lot of surgeons in the US had to stop doing lab Whipple because of our trial. So although academically, I still think if I would be in the same spot then without the knowledge now, I would do it the same, because I think it was the right thing to do. Sort of politically, it was for many people very difficult. And fortunately, I had a way out with the robot. So I think academically it's the right thing to do, but I still think politically it's difficult because people won't understand the results and it may kill the technique.
I guess also, Felix, the problem is that when do you say that the learning curve is achieved? So how do you know that you're getting people in the trials who are through it or not through it? There's a paper published this year by Shanghai group of 450 robotic Whipples, and they said their learning curve was 250. I mean, that was from changing from a blood loss from 400 to 300 mils or something, so maybe not clinically relevant. But and other places are saying that the learning curve's only 20, 40 cases. So it's different for each one. And I think, should you start the randomized control trials before the learning curve is reached, whatever you're setting your learning curve at? My answer would be no. I think that's just going to give minimally invasive surgery a bad name, because it is a technique that you have to learn first. And I don't think it would be fair to do a direct comparison of when you are starting. But that does mean then, are your first however many patients suffering? Potentially, but the more people who are through their learning curve and the more joint operating that you can do with someone else who's an expert, then maybe that's not so much of a thing if you're just starting doing parts of it, and then you have to have done so many parts of each operation before joining the randomized control trials.
I do think the learning curve is going down. So for the mastery phase in the Netherlands, it was 94 in all 7 centers. After 94, there was no further improvement. It was just purely because we followed the training program and didn't have to invent the wheel ourselves.
Jawad, I think you had your hand up for a bit.
Yes, I did. Thank you very much for fantastic talks, both of you. Just really just amazing talks. It's just, I have different approach to robotics. Robotics is quite new all over the world, In the UK, many centers are just buying the robots. So they are just buying it. Like in Scotland just installed 12 systems in the last 12 months. And they have like 2 or 3 more systems being installed. So robotics is quite new. And it just, not everybody has to do a robotic ripples. People should do robotic liver, atypical dissections, distal pancreatectomy. You know, like nearly 40% of people, only 40% of people do laparoscopic distals in the UK properly. And there's a very high conversion and all that. So not many do laparoscopic distal pancreatectomy or splenectomy. So there are lots of procedures that you can do before jumping onto the robot. And the misconception is that when you buy the robot, you have to do the complex procedure straight away. And I just don't agree with that. I think you just need to take your time. There are lots of examples. People had access to the robot and they played with it. And after some time, they realized that they have a ceiling of their interest. So they realize that it's probably not worth the stress or the effort or the money or the time for a very little benefit of a procedure, which is like they don't perform commonly. As I said earlier before this meeting, as per the HES data, in the UK, 90% of HPB surgeons, they do less than 10 ripples per year, 90%. If a surgeon is doing less than 10 ripples per year, they may think it's probably not worth the hassle of going to the robotic ripples. But there's lots of other procedures they can do, like distal pancreatectomy, spleen preserving and all that, and atypical liver dissection, which is like not commonly performed at the moment. So I think robotic ripples is not for everyone. It is important that you do it in a high volume center. It's quite important as a team, but you should not feel pressurized to do robotic ripples. If you have the robot, you're not obliged to do a robotic ripples. That's my only comment.
But Jawad, say in a UK system where you have, say, units with 6 to 8 HPB surgeons, how would you envision the division between lab, robot, liver, pancreas in a system where a patient expects to be operated by that surgeon?
Sorry, Marc, could you please repeat that, because I didn't hear the first part of your question?
Yeah, sorry, there was KLM flying by. No, so in a system like the UK where you have 6 to 8 HPB surgeons and you have pancreas, liver, lab, and robot, how would you envision who does lab distal, robot whipple, lab liver, robot liver, in a system where basically you got 6 to 8 columns without moving of these patients?
It's very, very difficult. So we talk about postcode lottery in the UK. So it depends, like the patients lives which area, and if they get referred to that hospital, they get a different level of care. And so there's a then lottery within the hospital, because like if there are like in my unit we have 4 HPB surgeons, and 2 of them do not do any robotic at all, and 1 does some robotic and some laparoscopic. And I do totally robotic. I have 3 lists per month. And all 3 of them, I do only robotic, liver and pancreas, whatever comes, I just do robotic surgery. So and it depends who gets referred to. So patients who come to me, they get robotic surgery. Patients go to a different surgeon within the same hospital, and they end up having open or laparoscopic surgery. We have tried at departmental level. It is difficult in the UK. It's just very, very difficult. You can't tell your senior colleagues, or you can't tell your colleagues in your hospital to do what you want them to do. And talking about the colleagues in different hospitals, that's impossible. It's the system in the UK.
So in our system, we have seven surgeons. 3 do participate in robot whipple. I'm the one always there. 3 of those 2 are the only ones who do lab distal, and 2 do only robot liver, and the others do only open. So we really split it up completely. But I understand it's difficult in a different system.
Marc, what you guys have achieved in Netherlands is just like Disneyland for us. It is honestly not possible where I work and where most of the people work in America. It is beautiful. It is absolutely gorgeous, but I'm afraid it's like not possible in many of the centers in the UK.
But I think that you then need to realize, what do I want? Do I want to start MIS HPB, which is, I think, requires such an approach, and other centers do it, or just keep doing open, which is fine. But I think this is the critical conversation we need to have.
So if you talk about laparoscopic surgery, let's rewind. Let's rewind 20 years ago when laparoscopic surgery was coming in, and only a select few were allowed to go into the laparoscopy because they were like cameras was not good. And for many 30 years, sorry, for many years I kept on learning and reading the laparoscopic surgery is dangerous and should not be performed. And then there was time when we had very few stacks available in the hospital. And then there was time only a select few were being allowed to do lap cholecystectomies, lap colons, lap appendix. When I started training, I asked for laparoscopic appendicectomy like in the middle of the night, someone, and they reported me to my consultant the following day that your training is very ambitious. You want to do lap appendix at like 12 at night. And now lap appendix is a standard procedure. So what I'm trying to say is the robot is a new surgical tool. People should be allowed to go on it. Trainees should be allowed to have training on it, but it should not be taken that they are obliged to do a Whipple's or major resections with it. We should start, and I think the future, the trainees, they will be stronger and better trained than us, and they will do take robotic to the next level.
But I must agree. I think the Netherlands is obviously a really good example of how well the cohesion and the collaboration is between units. And I think, Jawad, especially with you being on the GBI HPBA as a robotic lead, I think the OGES, GBI HPBA or ASGBI in the UK we should talk together a bit more and come with one sort of message to the NHS basically that this is if this is what he wants. So I think a bit of better collaboration in the UK will definitely make possible what Marc has achieved in the Netherlands. I don't believe that is not possible in the UK. I've worked in both systems, and I definitely see that we will be able to establish it. But it's a bit of a communication with each other.
Yeah, and we just have to go Dutch, Steen. Yeah,
double Dutch maybe.
Yeah. There's a quick comment from Christian actually. Will laparoscopy disappear in the future, being replaced by the robot?
So that Michigan data that I showed. They actually did find a reduction in their laparoscopic cases with the increase in robotic. So yes, there's going to be more robotic and less laparoscopic, but I do think laparoscopic is useful in some indications, especially so here in Australia they use the 3D laparoscopy, which I hadn't used before, and it's actually excellent. And that's one part of the robotic system that I love, is seeing strand by strand that beautiful picture, and you do get that on the 3D laparoscopies. I think there's still going to be laparoscopes that are available for theatres when the robot isn't, and for some procedures it's probably quicker to do laparoscopy for some general surgical procedures. I don't think it's going to go away. Then for liver, robotic, it can be challenging. There's not the right tool yet. You have to have a combination of laparoscopy. In Pittsburgh, the assistant uses the laparoscopic ligature for a lot of the dissection, so they don't have to change their instruments a lot, even during the robotic cases. So it's not going away. I think it's going to be a combination of using both. Now, is it going to be impossible to learn all these different techniques? I think trainees get a bit scared, and there's all these new robot systems and they're all different, and how can you learn everything? And I think, in the same way that you do some open procedures and some laparoscopic, robotics just going to be a part of that as well. And you will be able to change from one system to the other, depending on what theatre you're in and which operation you're doing.
Yeah, I think that's a fair comment. Felix, you've got a hand up? Oh, sorry,
yes. Yeah, no, because I just wanted to jump on a remark that Tamara made about different systems, because I think obviously Intuitive's been around, and this is specifically for HB surgery, I think, because it's so complex. I mean, Intuitive is a great system. I've used it in the Netherlands, but not in the UK. But and it is very intuitive, which is great. But I've also in wet labs used different systems from different companies, and these are, in my opinion, clearly inferior to because there's less articulation and these kind of things. So should HB surgery only be done with a specific robot? And obviously that also ties into costs of these things.
Well, I don't think there's a gold standard yet. We're too early on. Certainly, so Versius, I've done the simulation with Versius, and I actually think that it's fairly similar, because there's no advanced hemostasis yet with CMR, so I don't think you can do complex operations yet with it, unless you are using laparoscopy in the ligature a lot and you have a competent assistant. But they're a very sleek machine. I think there are certain advantages. Intuitive is let down sometimes with the movement of the robot, and that's what some of the Hugo and Versius are a bit different by. But I also was quite surprised that it won't take long to adapt between the ones. So when you do the you just have to learn your basic skills on the simulation, and that is different. And the camera moves slightly differently, and you have to readjust your muscle memory. But the procedural skills are the same. Where you want to put the instruments, your attraction, and how you're actually going to do the procedure isn't going to change. You just have to learn your basic skills for each platform. And all these robotics companies, Medtronic and CMR, are putting in huge amounts of money to future research. And I think it will be reasonable to use all types in the future.
Felix, I think you had your
Yes, thank you. I've got another question for Marc. You described a system where you only have 2 to 3 surgeons doing specific procedures like the robotic Whipple. Do you have the same, for example, for advanced vascular resections in pancreatic surgery?
Yeah. And the same for colorectal, same for upper GI. And I know that again is different from the German situation. But the robot Whipple are also the guys doing the advanced vascular resection, so that helps.
Okay.
And then the guys who do only open, they are transplant surgeons. So basically they only do clad skins and stuff like that.
All right.
But that's not the main point, the number. The main point is that I think that if you have 7 HPB surgeons and at the same time they all just want to play a little bit on a robot.
There's a few questions in the chat, one by Rashid and one by Naeem, and they're sort of similar, I think, so I'm going to put them together. Basically, Rashid asks, can you start with half a robot first and then do the full? So basically, he probably means do the resection part and then reconstruction open. And then Naeem's question sort of ties into that. What's your experience with lab hand assisted PD, especially for the reconstruction? Because clearly in the reconstruction, the robot will be superior to laparoscopic.
Yeah, I've seen everything and I heard all the options. Personally, I think the benefit from the robot during Whipple is bigger in the resection than in the anastomotic phase. With 3D, you can suture perfectly laparoscopically, it's no problem. But the robot gives you complete safety during the resection phase. If even a small branch, say an SMA bleeding, an SMA branch being you grasp it, full control. Talk to your colleague. What shall we do? Is it a bulldog clamp? You have full control. So, and I mean, if you would do the resection with the robot and then do open or lap, I don't think you need it. Although for the extraction side, we do as they do in Seoul, we make a small left upper abdominal incision of 5 centimeters, extract the specimen there, and then do the gastric edge open. Saves another 20 minutes, so we can finish in time and do another case after that. So no one knows. But doing a part lap, doing the full resection lap and then driving the anastomosis, driving a robot for the anastomosis, for me doesn't make sense because in my feeling and our Dutch feeling, the added safety for robot is mostly in the resection phase.
I think the reason you ask that maybe is because you feel more comfortable with laparoscopy and everyone prefers to operate how they feel more comfortable. But I guess with robotics is more and more and more you do of it, then that becomes your comfort. And you'd rather do it robotically. And I don't think there's any right or wrong reason it's or technique you should use. It's just whichever one you feel more comfortable with, and whatever you're doing most of, you're going to feel more comfortable with. And we've even converted back to robotic to do the anastomoses. So again, I've sort of seen it all as well.
And so the 2 main schools is important to mention. So there's one school who does where a senior surgeon does everything robotically, energy stapling, everything. There's a junior person with the sucker, that's school 1. And school 2 is what Pittsburgh taught and what we do in the Netherlands. Almost all but one center is 2 senior surgeons, one at the console, one at the bedside, sitting down, patient in French position, trocars a bit high. So the trocars are like this, so they don't smack you in the face. So the trocars, the robot trocars are like this. And the second surgeon has 2 hands, has energy, sucker, and a grasper, and is constantly operating laparoscopically during the entire procedure. And that goes a lot quicker and less blood loss. But those 2 techniques have not been randomized yet. So that may be something for the future.
Interesting question just popped up was, what is your experience with exploration for complications? Do you use a robot or do you go open?
I so far did lab. For instance, if you have I had one patient who had a hepatojejunostomy leak the first night. And so the next morning, very early, I just did the laparoscopic with 3D, put 2 extra stitches.
Okay.
And we had a patient who had a hepatojejunostomy occlusion after robot total. And for that one, I think we did a robot. So a few months down the line, a new robot hepatojejunostomy, and it's very perfect because there's no adhesions at all.
That's very impressive. You're doing your complications minimally invasively as well.
Yeah, well, that's the biggest benefit for the patients. I mean, the worst thing you can have is a bad pancreatic fistula with a laparotomy wound, which then bursts open. I mean, that's the real nightmare. So.
And Rashid asked the rate of postoperative fistula in robots. I think that.
Important point. So whenever we give a talk somewhere, when they start doing LearnBot, we say to the entire department, preferably including the colorectal and the upper GI surgeons there, and the residents, saying from now on, open Whipples will no longer leak in this department. Because the ones which are selected for robot are the ones who by definition will leak. So the only ones that remain open are the ones who had 6 months of FOLFIRINOX, and you can let the medical student do the pancreatic anastomosis and will not leak. So I wish someone told me that in the beginning, because after a few months in Amsterdam, the colorectal surgeons and the GI surgeons, they started talking. All the robot Whipples leak. All the robot Whipples leak. So, but if you do a match analysis, if you do randomized trial, leak rates are exactly the same, but you select the ones that leak. So please find someone in your unit to give that talk before you start. It will make your life a lot easier.
That makes a lot of sense.
It also comes. I think that answers Naeem's question, who asked what are your indications for an open PD. There's basically the more complex ones, I guess, Marc, or not?
Yeah, the ones who can't be done with the robot. Yeah.
That's vascular involvement. So
there's no universal agreement. There is something in the Miami guideline, but for us it's really important. CT scan maximum 28 days old. If it's 29 days, I do a scan, and we learned that in Diploma 1 trial and Leopard trials. So often there's a little bit of vascular involvement, and in the open days nobody cared. But now it's really annoying. Because there's nothing more annoying than after 3 hours in a robot Whipple, then you have to convert, because your outcome then will be worse, because you're just tired, your mindset, you felt like you lost the game. It's definitely not something you want. So you need a recent scan, and we do BMI below 35, but you can go up, of course, if you like.
Yeah.
So in our series of 65 Whipples with Professor Jawad Robotic, he does all cases as long as there's no vascular resection that you think is going to be required. Otherwise there's no limits, but we converted 3, and all 3 which we converted to open because of extensive vascular resection, we abandoned open as well. So I think you can do everything once you're through your learning curve and well trained. And vascular resection you probably can do as well, but it's not advised at the moment. I think mainly because people aren't through their learning curve, and you're getting the data together, and they're going to have worse outcomes if you do vascular resection. So it's, you don't want to risk that it's because of the platform that you're using that you're getting these outcomes.
Yeah, and people are looking closely at us. I mean, other surgeons are looking closely at us. If you kill a few patients with robot Whipple, and it's because we're in trouble. You can be in trouble in your hospital. It costs a lot of money. Hospitals don't like it. I mean, mainly Felix can say what 1 year robotic pancreas surgery cost them in Heidelberg. I know the figure. It's amazing. So I think my feeling is we have to be careful.
Felix, you put your hand up.
I've got 2 more questions. One, Marc, did you change anything to the anastomotic technique for the pancreatic jejunostomy from the modified Bloomgard technique? And do you see a role for other techniques more similar to the ones we use in open? And the second question is, you showed a slide with the operative times across the Netherlands, and if I remember correctly, there were a couple of RPDs around 200 minutes. Can you tell me which centers so I can go have a look how they do it?
Yeah, well, I can tell you very well. So the 2 lowest centers was us in Amsterdam, and one guy in Enschede was a general GI surgeon who does the operation every time with 2 scrub nurses, the same system. And he's very quick. Professor Long Liu in China does 3 robot Whipples on 1 day, finishes the last one at 7. So you can do it. So mostly if you want to gain time, you need to do clearly the running anastomosis on pancreas and bile duct. So that is that because the anastomosis take what is it, 2.5 hours. So if you want to gain time, you do it there. We changed very little. The only thing we changed is using proline for the pancreatic duct and no longer PDS, because there's some studies from Verona that the PDS just dissolves after 2 days, it's just gone. So, and the rest is, everything is exactly the same as in the Pittsburgh training.
Thank you.
Have you ever had any difficulty consenting a patient for a robot Whipple, Marc?
So in the beginning, we had a debate because we had centers who started with robot Whipple for surgeons who couldn't even do a lap chole, barely. No, honestly.
That's crazy.
No, honestly. And their results are perfect. No, so in the 3 learning curves, morbidity before and after the learning curve cutoff point is exactly the same in all centers. What we do see with laparoscopic experience, your learning curve is 20 Whipples shorter on each of the 3 learning curves. Consenting was clearly challenging, but so for instance, when we started with laparoscopic Whipple, we said, well, we have done, I don't know, at that time 60 laparoscopic distal, we're going to do your procedure with an experienced someone there, do it on the table, etc. And then thereafter, the second and the third and the fourth case is clearly a bit more difficult. We had no problem, and the reason mostly is that there's such a trust in society for robotic surgery. As soon as you say robotic surgery, people are like, oh yeah, oh, let's do it, no problem. I mean, then you say you're gonna have chemo, they're like, no chemo,
Okay.
robot surgery today, but no, please, no chemo. I don't know if it's in your countries, but that's in the Netherlands, that's crazy.
Yeah, robots are exciting and new, aren't they?
Can I ask Marc and Tamara, please?
Oh, go ahead.
Yes. How do you find it safe to dissect through the para-aortic lymph nodes? You are doing a robotic Whipple. If you want to see the para-aortic lymph nodes, it is detected in the CT scan.
It's very difficult to hear you.
Yeah, Rashid, I think you have to repeat that again, please.
Yeah.
How do you find it safe to dissect through the para-aortic lymph nodes? It is detected in the CT scan. When you do robotic Whipple.
Yeah. So normally we don't take para-aortic lymph nodes. If the para-aortic lymph nodes look big on the CT scan, we do a puncture, CT guided pre-op, and if they're positive, we go for surgery first and probably abandon altogether. But during surgery, if you want to, is no problem at all. So you have such a great view. I mean, you can do beautiful dissection. Actually, you have to tell yourself stop because you just want to continue and take out stuff. It looks so great.
There's a question from Oguzan. I'll shorten it. It says, with your permission, I want to ask, isn't it important that companies, I assume he's meaning CMR and Intuitive, increase the opportunities and help to shorten the learning curve?
Yeah, Oguzan was just with me for 2 weeks from Bursa in Turkey. No, I fully agree. I think if you give someone a robot and they want to do a procedure, you should help them with training. And so, for instance, LearnBot is paid by Intuitive. The only thing they gave to us was salary for a PhD student, but they pay for all the travels, so going back and forth. And they now also actually discourage a center to do robot Whipple if their overall volume is less than 50. They're now pretty tough at that because you know what happened in the US? Very negative press for robotic surgery because these very small centers just put a robot sign on the building trying to attract patients, earn money, but do then too few cases. And it was very bad press for robotic surgery in the US. So they are now, Intuitive is now stepping up, setting bars, volume cutoffs for complex surgeries. But I think that they should do more, invest more, give money to EHPBA, whatever, invest more in the training. Yeah.
Yeah, and I think that's what Intuitive haven't done is they've been quite strict for obvious reasons about who can train, but it means they're not training any junior trainees or consultants just in using the console in itself rather than doing complex operations. And I think they've missed a trick there. And Versius in the UK has got a very, very strong trainee program. They're working with ASSET, the Association of Surgeons in Training, quite a lot. And I think they are starting to develop more courses with trainees rather than just waiting until you can definitely do robotics in your center.
Has anyone done a Whipple with a CMR Versius?
No. There's no advanced hemostasis with CMR. I think someone did a left hepatectomy, I think I saw last year. I can't remember which center. Was that you, Jawad?
No, it was the left lateral. No, I didn't do. I don't have CMR. It was someone, I think they did left lateral somewhere in India.
So we are getting the CMR and the UGO to the Amsterdam Skills Center and repeat the study we did with biotissue suturing, Da Vinci 3D and 2D to see whether it's actually non-inferior and how the OSAT scores, etc., compare. But that's not in patients. That's just biotissue.
Are there any studies in ergonomics of surgeons? Because I think that's one of the big. You mentioned a few times already, Marc, that you feel rested after a Whipple. I don't.
Yeah,
feel
it's like robot
Whipple.
Whipple. Really, honestly, it's like yoga. I mean, if it's a normal patient, you feel so much better at the beginning of the day. In the Diploma 2 trial, we do have a questionnaire at the end of the surgery for the surgeons, a questionnaire about stress and you feel shoulders and stuff like that. I also know a story about a surgeon, famous Belgian surgeon, who on day 2 robotic surgery got a cervical hernia. Because it probably has been a problem for a long time, but Intuitive don't train you. If you sit at the robot the first time, you need someone to make a photo from you from the lateral side to see whether your spine, cervical spine, is all in one line. A lot of surgeons, they sit like this at the robot and no one teaches you. And I know this story from my wife, who's an ophthalmology surgeon in kids and operates to the robot. There they teach each other, and plastic surgeons teach each other how to sit at the robot. We don't teach each other. So there are some tips and tricks there about your positioning. And I think also maybe Tamara can comment, but Intuitive needs to train surgeons better how to position themselves ergonomically.
And there's different problems. People get calluses on their hands and things, which is a little bit different. But no, I agree. I think the other, being in that console, you're just completely focused. And I think it's like meditation because it's just you, the console, the operation, and your total focus what do they call it? Flow something, meditation. And so you do feel better after doing a robotic procedure.
It's very addictive, robotic is.
Very addictive, yeah. Beautiful.
It's a selling point to get it over the line, maybe in some countries where buying it is a bit more difficult.
We are very privileged that we have access to the robot. 85% of the population in the world do not have access to a laparoscopic surgeon, 85%. And we are like less than 1% of some like people who have access to the robot and doing major surgeries. So we are very privileged.
Well, with that, I think we're nearly 90 minutes in now. I'm not sure if I did all the questions in the chat. If I've got one, I'm sorry for that. I think it was an excellent talk. I don't know if any of the panelists want to add anything at the end.
Just wanted to add something that Professor Besselink, like what you have done and achieved is amazing. Honestly, we all envy you a lot, and we all wish that we can do 10% of what you have done and achieved. So many congratulations, and please keep leading the way. Your training program for the Whipples is absolutely amazing, and I have no doubt if somebody goes through a structured training program, what you offer, the outcomes will be a lot better. But I just like
sorry, I just need to correct you. It's Melissa Hawk's training program.
Yes,
we just copied it to the Netherlands and Europe. It's not. I didn't set it up. It's Melissa Hawk.
But it just says that the only slight anxiety I have is like many of the centers in the UK will be excluded. Many of the surgeons in the UK will be excluded because unfortunately the centralization is not working in the UK. And majority of the centers, as I've earlier said, 90% of surgeons in the UK do less than 10 Whipples per year. So having a line drawn at 50 per year, many of us are excluded already. I'm excluded. So
per center, Jawad, it's per center, not per surgeon.
Yeah, per center. Yeah, even per. So if a center has 50 pancreas per year, and then there are like 8 consultants there, so it's still like 8 consultants doing Whipples. But anyway, what you have done is absolutely amazing. Really very impressive work.
Yes, and that again, I agree with that. The results are really great. And shame, Melissa, we asked her to join as well today, but she was unfortunately stuck in theater. So it would be great to have heard from her as well. But I think we had a really great evening, in my opinion. Thanks, Marc and Tamara. Thanks, Felix, Christian, and Jawad for joining us as well. Thanks for all the delegates and all the excellent questions.
I think Felix has disappeared already, but yes, thank you.